Welcome to the Explainer. Today we're jumping right into a pretty fascinating physiological condition known as diabetes insipidus. We're going to literally peel back the layers on the exact machinery your body uses to keep its water levels perfectly balanced, and, more importantly, we'll see exactly what happens when that vital system completely goes haywire.
But before we get bogged down in the biology, I've got to ask you a question, and it's a little gross. Did doctors really used to taste their patients' urine? Well, yeah, they absolutely did. Back in the day, tasting urine was actually a primary diagnostic tool to figure out what was going wrong inside someone based entirely on the flavor. And as unsettling as that is to think about, it is actually the perfect gateway to understanding the name of the very disease we're looking at today.
See, when you hear the word diabetes, you probably immediately think of blood sugar, right? But the word diabetes itself simply translates to an increased passing of urine. It's that second word that tells the real story here. Insipidus literally means tasteless. So diabetes insipidus is characterized by making massive quantities of extremely dilute, totally tasteless urine. And this is the historical contrast to the much more famous diabetes mellitus, where mellitus means sweet tasting because of the excess sugar spilling into the urine. For our explainer today, though, we are focusing strictly on the tasteless, high-volume flow of diabetes insipidus.
All right, here is our quick roadmap for today. We're covering 1. The tasteless urine. 2. The body's water managers. 3. The 4 types. 4. Diagnosing the problem. And finally, 5. Fixing the flow. Okay, let's move right into Section 2, the body's water managers, normal physiology of hydration. Let's set a baseline for how a healthy system is actually supposed to work. Let's walk through this whole biological relay race. It all kicks off in your brain, specifically in the hypothalamus. You've got these tiny sensors up there called osmoreceptors, and you can think of them like quality control managers for your blood. They are constantly measuring your blood osmolality, which is just the concentration of dissolved stuff, like glucose, sodium, and urea floating around in your blood plasma. Normal osmolality is a really tight window, sitting between 285 and 295 milliosmoles per kilogram. Now, when you get dehydrated, that concentration obviously goes up. So, step 1. Those osmoreceptors detect the high osmolality, and they do 2 things. First, they make you feel thirsty. Second, they signal a very specific cluster of neurons to jump into action. That brings us to step 2. The signal travels to the posterior pituitary gland, which dumps a hormone called antidiuretic hormone, or ADH, into your system. You might also hear it called vasopressin because it also constricts blood vessels to bump up blood pressure. In step 3, this ADH travels all the way down to your kidneys, specifically hunting down the distal convoluted tubules and collecting ducts of your nephrons. And then step 4 is where the real magic happens. The ADH bonds to a receptor, vasopressin receptor 2 to be exact, which tells these special proteins called aquaporins to physically embed themselves into the cell walls.
So, what exactly are these aquaporins? Picture them as highly exclusive microscopic gates. When they embed into the nephron cells, they pop open and let water, and literally only water, travel out of the kidney tubule and get reabsorbed right back into your bloodstream. This immediately dilutes your blood, bringing that osmolality perfectly back to normal. This entire reabsorption process is what decides exactly how much water leaves your body as urine, which normally keeps your urine osmolality concentrated somewhere between 300 and 900 milliosmoles per kilogram. It's just a stunningly precise feedback loop.
But what happens when that system fails? Well, the kidneys end up reabsorbing way too little water, and the result? A person dealing with diabetes insipidus typically cranks out over 3 liters of extremely dilute urine every single day. That's a massive amount of fluid. This symptom is called polyuria. And because you're losing so much water, your blood concentration spikes, which triggers this extreme, practically unquenchable thirst known as polydipsia. If this goes unchecked, losing water that fast leads to severe dehydration, tanking blood pressure, fatigue, nausea, and even intense, dangerous confusion.
Which brings us right to Section 3, the 4 types, when the system breaks down.
All right, so if someone is producing over 3 liters of urine a day, the malfunction can actually originate from 4 distinctly different places. Think back to that biological relay race. You have a message being sent from the brain down to the kidneys. On the one hand, we have central diabetes insipidus. This is a brain issue. The hypothalamus or the pituitary gland is damaged, maybe from head trauma, or sometimes we don't even know why, and it completely fails to make or release ADH. The messenger key is just missing. No ADH means no aquaporin gates open in the kidneys, so the water just flows straight out of the body. On the other hand, we have nephrogenic diabetes insipidus.
This is the kidney issue. The brain is doing its job, sending out plenty of ADH, but the kidneys are completely ignoring it. The locks at the kidneys are broken. Why does that happen? Well, it could be a genetic defect in the receptors, it can be caused by certain medications like lithium that mess with aquaporin production, or it could be from underlying kidney disorders.
Our third type really grounds this condition in the human experience. Gestational diabetes insipidus happens specifically during pregnancy. The brain is working fine, the kidneys are working fine, but the placenta actually starts releasing an enzyme called vasopressinase, and this enzyme's only job is to literally hunt down and destroy the mother's ADH before it ever reaches the kidneys. This usually kicks off around week 8 and peaks in the third trimester, meaning that intense thirst and constant urination just keep getting worse right up until birth when the placenta is safely removed.
And then we have our fourth type, Dipsogenic diabetes insipidus, sometimes called psychogenic polydipsia. This one flips the script entirely. Instead of a broken system causing dehydration, this is caused by the patient just drinking way too much water. It's often psychological, frequently seen in folks with conditions like schizophrenia who might compulsively drink water. Because they are absolutely flooding their system, their blood osmolality plummets. The hypothalamus sees this and does exactly what it is supposed to do. It shuts down ADH release to let the kidneys get rid of all that extra water. The machinery isn't broken at all. It's simply being overwhelmed by what's coming in.
Okay, moving right along to section 4, diagnosing the problem, the water deprivation test.
So, put yourself in the doctor's shoes. You have 4 different types, all presenting with the exact same primary symptoms: massive urination and massive thirst. How do you figure out which link in the chain is actually broken? Well, doctors become biological detectives, and they use this brilliant little cheat sheet. They usually start with a water deprivation test. Basically, they just ask the patient not to drink any water for a few hours. In a healthy person, your urine would get highly concentrated, but in someone with diabetes insipidus, their urine stays alarmingly dilute, below 300 milliosmoles, because their body literally cannot hold on to the water. But here is the really clever part. The doctor then gives them an ADH analog called desmopressin. It's basically artificial ADH. If you give them this artificial ADH and it suddenly fixes the problem, concentrating the urine normally, boom! The detective work is done. The patient's brain just wasn't making ADH. That proves it's central, or gestational if they're pregnant. But if the doctor gives the artificial ADH and the urine only concentrates a tiny bit, that tells us the kidneys are stubbornly refusing to respond to the hormone, which confirms nephrogenic DI. Finally, if the very first blood test shows normal or low blood osmolality, they don't even bother with the deprivation test. They just monitor the patient to confirm they're compulsively drinking too much water, which diagnoses dipsogenic DI.
And that brings us to section 5, fixing the flow, targeted treatments.
Now, obviously, once you diagnose the exact malfunction, the treatment has to specifically target that broken link. You can't just hand out one pill for all 4 types. The solutions are actually as logical as the condition itself. For central and gestational DI, the body is missing ADH, so we just replace it with desmopressin. Simple enough. For nephrogenic DI, the kidneys won't listen to ADH, so doctors use a really clever trick. They prescribe thiazide diuretics. Now, giving a diuretic to someone who is already peeing too much sounds completely backwards, I know. But these drugs increase the excretion of sodium in the urine. Because sodium is a huge factor in blood osmolality, getting rid of the sodium actually drops the blood concentration, which stops the hypothalamus from desperately triggering that thirst response. It is a fantastic biochemical workaround. Finally, for dipsogenic DI, since the biological hardware is working perfectly, the treatment relies on behavioral therapy to help the patient safely dial back their compulsive fluid intake.
We have covered a lot today: the history, the biology, the breakdowns, and the targeted fixes. From osmoreceptors in your brain all the way down to those aquaporin gates in your kidneys, your body is performing millions of microscopic calculations right this very second just to keep your hydration perfectly balanced. So I want to leave you with a thought to chew on. Knowing how delicately this entire system is balanced and how extreme the consequences are when just one single step fails, how perfectly are your own biological water managers working right now? It really does give you a profound appreciation for the hidden, elegant physiology inside us all. Thanks for joining me on The Explainer today. Keep learning, and I'll catch you next time.